Okay, so we did our auscultation tips and then we talked about what normal breath sounds are. And now we'll kind of talk about what not normal breath sounds are. The most important thing you can take away from the auscultation is practice, 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 and practice on people young and old that you can, and get used to getting in a kind of in a, it's almost like it's memory at some point, and you get this little routine where you figure out where you're going to start listening to the lungs, and you think about doing equal sites and to see if they're equal and bilateral. So equivalent sites on each side. Make sure their breath sounds are equal and bilateral. Make sure you're listening through the whole inspiratory and expiratory phase. And then, of course, identifying what we're hearing. So adventitious breath sounds, so breath sounds that aren't normal. So diminished breath sounds aren't normal. There's something that's causing a decrease in airflow, or for some reason the sound isn't transmitted as it is with normal breath sounds. Bronchial or tubular breath sounds, and we'll talk about what all these mean. Crackles, wheezing, rhonchi, stridor, pleural friction rub, egophony, and bronchophony are related to vocal fremitus. So we'll touch briefly on all of these adventitious sounds. Say nothing, they'll blame the dog. It's pretty cute. So diminished breath sounds. And when I'm listening and I'm hearing something adventitious, this is how I like to kind of think about, this is my schematic for thinking about the adventitious sounds and identifying it. So what, when, where, and why, and then also at the end of the what, when, where, why, like what are our treatment options for something that is causing this sound. And that'll kind of come later as we start more of our, as we start our clinicals and we try to figure out what we have in our toolbox to help with all these adventitious sounds. So diminished breath sounds, what? Normal breath sounds without the same pitch or loudness. So a low sounding or not as much airflow as you heard with your normal breath sounds. And that's why it's so important to hear as many normal breath sounds as you can, so that when you do hear an adventitious sound, you know immediately it's not the same pitch or loudness, it's a diminished breath sound. So it can be inspiration and exhalation, where all lung fields, why it's reduced sound transmission, so too little airflow or too much trapped air, shallow or slow breathing, plugged airways, hyperinflated lung tissue, air or fluid in the pleural space, generalized body edema or obesity. So too little airflow or too much trapped air, that's kind of an obstructive lung disease thing where you have a decreased airflow and some obstruction, so you get air trapped on the wrong side of the airway that's closing off, and your alveoli are too full of air, and that causes you to not be able to have as much airflow. Shallow or slow breathing, so that's an anesthesia thing, a sedation thing, or somebody that's failing with their respiratory status. Plugged airways can be secretions, it can be some kind of a obstruction, something where you're just not getting as much air flow through there. Hyperinflated lung tissue, and we kind of talked about that with the obstructive lung disease. Air or fluid in the pleural space, pleural effusion or pneumothorax. So if you have air or fluid in the pleural space, your lung's not going to have as much room inside your chest cavity to expand, and that's going to cause a decrease in airflow. Generalized body edema causes the same thing. Obesity causes the same thing. You're just not able to always lift that chest wall. So those are some, here I go again, some reasons for diminished breath sounds. What do? You see if there's anything you can do to inflate the lung tissue. You have to treat the cause pretty much. So when we think about the why are we hearing these, we have to treat the cause. Chest x-rays for diminished breath sounds. Oh, my mouse is back. Okay, so this is a pleural effusion. So there's fluid in this pleural cavity, and that's not allowing that lung tissue to expand appropriately. So if you're listening posteriorly or even anteriorly, equivalent sites on each side, are they going to be equal and bilateral? No. this is going to be a decrease in airflow, because when you see these flat diaphragms on a chest film like this, and I don't want you guys to worry too much about the chest films because we will be going over those on week 4 and talking about that, but that's just trapped lung tissue, and I'm sorry, trapped air in the alveoli on the other side of an obstruction. So it flattens out those diaphragms from having trapped air, and this is like a COPD patient is going to have this, and a couple other reasons for diminished breath sounds. I had links to all of these on here, and I put them on Blackboard because I think it'll be easier for you guys to access them through there. So, and I labeled them all so you guys can go through and listen to the breath sounds, diminished, and all of these adventitious sounds right from the Blackboard site. It's right on the learning module for auscultation. So instead of trying to embed them into the PowerPoint, I just went and put them on Blackboard for you. So, no, Cardi B is not short for cardiovascular bronchitis. I just thought that was funny. So bronchial breath sounds, what are they? They're considered abnormal if they're heard over the peripheral lung regions. So normal, they'd be considered normal if they were heard more in the larger airways. But if this is out in the periphery of the lungs where it's supposed to be a little bit quieter, we call these bronchial breath sounds. So it can be on inspiration and exhalation, and the duration of sound is equal during inspiration and expiration. So typically you know that your inspiratory to expiratory phase is like 1 to 3, or with a COPD patient like 1 to 5. But when you hear these bronchial breath sounds out in the peripheral lung region, so way out near the alveoli in those small airways, and you hear the equal inspiration and expiration, sometimes we'll call those bronchial breath sounds, and they're way out in the periphery of the lungs, and they're heard if the lung tissue density increases. So you think about how sound travels through a dense material. And so atelectasis, which are collapsed alveoli, so a density of collapsed alveoli pneumonia, where you have probably some atelectasis, but also some infection in an area of the lung that causes bacteria in there. Cavitation, same thing, hydro or pneumothorax. It may consolidate that lung tissue out in the periphery if you're not able to expand your lung because there's water or air in the pleural space causing that condensed tissue. So treating the cause is important with that, and you have to determine why you have the bronchial breath sounds. And so essentially the things to take away from that are they would be normal, except for the I to E is about the same for the sound is similar in inspiration and expiration, and it's way out in the periphery, and you shouldn't hear that much airflow out in the periphery of the lungs. So you can see here, there's this condensed tissue. You can see that this airway here, and you will be able to hear, you shouldn't be able to hear the airflow that you would hear out through here. So a couple of places of consolidation and a couple of areas where you might hear some bronchial breath sounds if you're auscultating in that area. Okay, crackles. And I put on the Blackboard site, I put crackles. I did fine inspiratory crackles and then coarse crackles. And realistically, these two pictures are a very good depiction of what you hear when you're auscultating on inhalation. And typically crackles are on inhalation, but not always. Or if you rub your own hair together by your ear, like take your hair and rub it together, that's kind of what crackles sound like. So these are two very good but strange pictures that give you an idea of what crackles sound like. What is it? Like hair rubbing together or Rice Krispies. When inspiration and expiration, when it's secretions, inspiration when the alveoli are popping open. So sometimes you can have crackles from secretions, and you can hear, essentially it's the alveoli coming open. If the secretions are in the way and it's fluid moving around, you can hear crackles on inspiration and expiration. A lot of times when the alveoli are popping open, if you think about the inspiratory phase of respiration, when you breathe in, you're filling up your lungs and your alveoli should be popping open. So if it's an atelectasis problem or a lung disease problem, where the compliance is low and the alveoli are closing on exhalation, you're going to hear the crackles on inspiration, because that's when the alveoli are getting that enough pressure there to open those up. So where peripheral airways, if it's secretions, or the alveoli, if it's the atelectasis and the alveoli are coming open. So you're going to hear crackles way out in the periphery of the lungs. You're not going to hear crackles in your bronchi or your trachea or anywhere where there's a lot of airflow, because it's a manifestation typically of the way far peripheral airways, the little tiny airways at the end, or the alveoli coming open. So why secretions in the airways? That's more coarse crackles, or alveoli popping open, that's fine crackles. Intervention, you can try deep breathing and coughing. That's kind of the easiest one we can do to see why those go away. And we talked about why we start at the bottom of the lungs for our auscultation sites, because we can see if they're benign crackles. So if they go away, we were able to treat the crackles with just deep breathing and coughing, because your patient's taking deep breaths for your pulmonary assessment, or your auscultation portion of your assessment. So that's why we start at the bottom, because that's a lot of times you'll hear the crackles in the bases of the lungs. Chest x-rays. So here's some atelectasis. You can see, and you guys will learn all about this. I don't want to scare you with that. This is some interstitial kind of a lung disease or an ARDS, and I don't know if it's chronic or acute there. So probably some crackles there, and then so just a couple of different things that present in that way. Ooh, yikes. Okay, I'm not sure what these are. I guess we just need to take a second and breathe. Okay. You said you heard wheezing. My stethoscope determined that was a lie. So that's funny. So wheezing, and you'll hear a lot of this in your career, and this is, patients with asthma, patients with COPD. What is it? It's a high-pitched noise as air moves through obstructed airways. So it really does kind of sound like you're letting the air out of a balloon and holding it and squeezing it, like the top of it. It's high-pitched, and it typically, not always, but mostly on exhalation. So a lot of times you'll hear an expiratory wheeze, or you'll hear the wheeze on exhalation. And this is why it's so important to listen to a full inspiratory and expiratory cycle for these patients. It's in the smaller airways in the periphery, although wheezing can resonate all throughout the lungs. So sometimes you'll put your stethoscope, closer in on the posterior side, and you're thinking you're going to be somewhere around the bifurcation of the bronchi, and you can hear the wheezing there, and it oftentimes resonates throughout the lungs. Typically it originates in the smaller airways, where they lose their ability to hold themselves open. If we think about what we saw earlier with the anatomy, where the trachea has the cartilaginous rings, as the lungs branch off and bifurcate down, they don't have as much cartilaginous structure, and they start to have the inability to keep themselves open. If you have a patient with obstructive air disease, or reactive airway disease, where those smaller airways close off. So that's what you're hearing, is the air trying to move through those narrowing or obstructed airways of some sort. So like we said, they're in the smaller airways in the periphery, although they can resonate throughout all the lungs. Why restricted and or obstructed airways? And I hope that makes sense, and we will make it make sense at some point in your assessment class here. Intervention, typically we've got to open up that airway, and so a lot of times we do pharmacology, bronchodilators to help open those up. Also deep breathing and coughing, because that helps us determine if it's a wheeze or if it's a bunch of secretions in there and it's actually bronchi. So secretions will clear with a cough, bronchospasm and obstruction will not. So if we have them take a real deep breath